Good morning, dear friends. I am Dr. Jambukeshwaran, prep ladder orthopedic faculty for you. So today's session, we are going to do rapid revision session. Okay, probably I hope you would have seen the full video. I had done 16 to 18 hours of ortho video for you already. So rapid revision, I tried to cover everything by 3.5 hours, you say, and we'll touch only the important points. So just it's like a summary. The same slides will come. It's like a summary. It's a revision for you. Okay. So whenever you need some detailed discussion or any doubts, kindly refer the main video. Right? Straight away, we'll move on to the first topic, fracture. First, we should know what is a fracture, how a fracture is classified. Fracture is correctly defined as a breakage in continuity of the bone or periosteum or both. The point I want to stress is, even there is a breakage in periosteum, that is also called a fracture. That's the very important thing, just I want to tell you. Okay, so fracture is defined as a breakage in the continuity of the periosteum or bone or both. This is called a fracture. Okay, so how a fracture is defined, classified according to AO classification. AO classification system is the most accepted classification system throughout the world. How it is being classified? Broadly classified into two types. Okay, one is called typical fracture. One is called a typical fracture. The another thing is called an atypical fracture. Atypical fracture. Just in a nutshell, I'll tell you what do you mean by a typical fracture. Typical fracture means fracture which presents with all or most of the clinical signs of fracture. So when a fracture presents with most of the clinical signs, then it's called a typical fracture. It's satisfying all the criteria. Then we should know what are the classical signs of a fracture. The most common sign is tenderness. Second thing, swelling. Third thing, deformity. Fourth thing, abnormal mobility. Fifth thing, crepitus. Sixth thing, loss of transmitted movement. I repeat once again, tenderness, swelling, deformity, abnormal mobility, crepitus, loss of transmitted movements. There are 6 classical signs of fracture. Any fracture anywhere in the body can present you with these 6. So, whenever a fracture presents with 2 or more signs of these clinical features, then it is called a typical fracture. Typical fracture. When they present without clinical sign, only accidentally or otherwise the patient's complaining of pain, you are taking an X-ray. X-ray shows you an incomplete fracture or just breakage in periosteum alone. Then it's not giving the classical signs of fracture. Then it is called an atypical fracture. That's all. So this is the definition of a typical fracture and an atypical fracture. The typical fractures are divided into 5 types. What are the 5 types? Number, you look at this diagram. So this is the proximal fragment. This is the distal fragment. You are seeing a fracture line here and it is transverse. So the first type is called transverse. Okay. Depending upon the fracture pattern in the X-ray, the first type is called transverse fracture. Look at the second diagram. Fracture line is there, but it goes obliquely like this. So this is called oblique. Look at the third type. It is in a spiral form. So this is called spiral. Look at the fourth type. Proximal fragment is there. Distal fragment is there. In between, a separate piece of bone. So this is called segmental. The segmental fracture, or this is in radiology, they will call this as butterfly fragment. Okay, so this is called segmental fracture. Look at the last type, shattered into many pieces. So this is called comminuted. So typical fracture can be of 5 types: transverse, oblique, spiral, segmental, comminuted. Okay, it's called, see, transverse, oblique, spiral, segmental, comminuted. That's all. These are the 5 types of typical fractures. Among this, frequently asked MCQ is, which has the best prognosis? Oblique has the best prognosis. Why it has the best prognosis? You see, This is the raw surface area. Okay, just to see, dear friends, please concentrate. So this is the raw surface area that is coming into contact. In transverse, this is the raw surface area that is coming into contact. Okay, which has more raw surface area? Oblique has more raw surface area than transverse. So when raw surface area is more, area coming into contact is more. When that is more, the electric current that is induced in that area is more. When electric current induction is more, hematoma formation will be more. When hematoma formation is more, callus formation is good. When callus formation is good, prognosis excellent. This is the theory. So which has best prognosis among the 5 types? Oblique. So transverse has very good prognosis. Very good prognosis. This has the best prognosis. Spiral, what happens? No, spiral, the proximal fragment is like this, distal fragment is like this. They will unite well, but they will unite in a rotated form. So union happens, but definitely there will be malunion. So prognosis, I can't say bad, good. So just you classify best, very good, good. The problem with this, okay, the problem with this segmental and comminuted is, you see here, proximal fragment is here, distal fragment is here, in between a separate piece of bone, and that piece, proximal fragment has its own blood supply, distal fragment has its own blood supply, the in-between separate segment, the butterfly fragment, is devoid of blood supply. So 100% if you don't treat it properly, this will go for avascular necrosis and non-union. So this has worst prognosis. Same thing, comminuted, shattered into many pieces. If you don't fix it properly, this high chance that this can go for non-union. So this again has a very bad prognosis. Okay. So dear friends, this is about typical fractures. Once we finish this, right, when you go to atypical fractures, look at the first type of atypical fracture. When you see here, this is one cortex, this is another cortex. One cortex is intact, the another cortex is open, broken like this. One cortex is intact, another cortex is open. So this is an incomplete fracture. That's why all these are coming under atypical. All these are atypical fractures. Typical fractures are over. So atypical fracture, you see one cortex is intact, another cortex is open. So this is called a green stick fracture. You see this X-ray here? This cortex is very much intact. Here you are able to see a gap in this X-ray. So exactly, this is a real X-ray of one of my patients. Okay, a forearm X-ray of one of my patients. So this is one cortex is open. So this is a classical green stick fracture. What are the points to be noted in green stick fracture? Green stick fracture exclusively happens in children before epiphyseal closure. It is more common in forearm bones because of fall on outstretched hand. Okay. Why it's called green stick fracture? What is a green stick? Everyone knows it's a literal meaning of green stick. No, green stick. What is green stick? Green stick is nothing but a young bamboo. Bamboo, you would have seen a matured bamboo is yellow in color and it is this much width. Young bamboo is green in color and the diameter is very small. That is why it is called green stick. When you take that green stick, young bamboo, try to break, one cortex will be open, another cortex will be intact. So this is compared with that green stick. So this is called a green stick fracture. Then the last point, what is the treatment of choice? What you should do for a green stick fracture? Just like that, when you give POP, since one cortex is intact, another is open. When you give a POP, this continues to grow. This continues to grow because one cortex is intact. Another cortex, it is open, no? So what happens? Sometimes this part can go for non-union. Okay. So to avoid this, what we have to do is break open the cortex, the other cortex also at the same level. Break it. Then you give a POP. Obviously, okay. Obviously, when you give a POP, it will have an excellent prognosis. So that's the treatment. So what are the points in green stick? Green stick fracture happens exclusively in children before epiphyseal closure. Forearm bones are commonly involved. One cortex is open, another cortex is intact. The treatment of choice is break open the other cortex also and treat it conservatively with plaster of Paris. This is green stick. The second atypical fracture This is a diagram, not a real picture. This happened. This is otherwise called this fracture is called a March fracture. This is called a March fracture. This is otherwise called a stress fracture. This is otherwise called a fatigue fracture. Fatigue fracture. Otherwise called a hairline fracture. 4 synonyms are there, dear friends. March fracture, stress fracture, fatigue fracture, hairline fracture. So when you look at this, no, it looks like a hairline. Patient will complain of only pain. Most common site of this March fracture, stress, fatigue or hairline fracture is the neck of second metatarsal. The most common site is the neck of second metatarsal bone, foot. This happens in those who walk for a very long distance. Who will walk very commonly? Soldiers will walk. So this is very common in army personnel, very common in police recruits. And osteoporotic bone, already a weak bone, those who stand for a long time, theatre staff nurses, stands for a long time. Without any trauma, the neck of the second metatarsal is gone because weight bearing. That is why since March past is causing that, it's called a March fracture. Since this is happening without trauma, this is called a stress fracture or a fatigue fracture. Simple X-ray, this is not seen. When you take a digital X-ray or a CT scan, you will see a hairline like thing, so it's called a hairline fracture. Okay, so these are the synonyms. Treatment, very simple. What is the treatment? Conservative. What is that? Bed rest and non-steroidal anti-inflammatory drugs for 14 days. That is the treatment of choice. This is the second atypical fracture. Look at the third atypical fracture. Look at this diagram here. This is femur, this is tibia, this is tibial tuberosity. Okay, this is tibial tuberosity. This is quadriceps tendon, patella, patellar tendon, and this is tibial tuberosity. So a fracture is happening at the site of patellar tendon, okay, at the site of tendon insertion, the sites of tendon insertion. Even when they ask a question, what is the most common site of avulsion fracture? This is called an avulsion fracture. This is called an avulsion fracture. When they ask in a question, no, what is the most common site of avulsion fracture? Tibial tuberosity is the answer. The second common site is tendoachilles getting inserted into the calcaneum. Tendoachilles getting inserted into the calcaneum. So this is an avulsion fracture. Even though this fracture looks very simple, the problem is the patellar tendon is constantly being pulled. The patellar tendon pulls the small fragment. So even though this is a very simple fracture, when you don't fix this with a screw, this will go for non-union because one fragment is constantly pulled by the patellar tendon. So it needs fixation. Even though this is simple, all avulsion fracture needs fixation. Okay, good. So this is the third atypical fracture. Look at the fourth atypical fracture. Classically, this happens in vertebra. Normal shape of vertebra is rectangular or square in shape. What happened here? The shape became wedge. So this is called wedge. So this is called a wedge compression fracture. This is called a wedge compression fracture. Right? Wedge compression fracture. So this is called a wedge compression fracture. Most common site is T12. Then comes L1. Most common site is T12. Why T12? It's more common because that is the most weight bearing vertebra in our human body. Okay, 33 vertebrae are there. The most common vertebra to undergo wedge compression fracture is always T12. Okay, again the same T12 will come in one more place that I will highlight, skeletal tuberculosis, that will come. Okay, so T12, most weight bearing vertebra. Wedge compression fracture. This is a harmless fracture. This happens mostly as a pathological fracture. Osteoporosis is the pre-existing pathology. Osteoporosis of the bone, there is a pre-existing pathology. So due trivial form, usually you know the mode of injury. This happens in an elderly individual. Already they are osteoporotic. The bone is weak. They'll be sitting in the last row of a government bus. The driver will be riding, say, has 80-100 kilometer speed. There will be a speed breaker. He may not be noticing that. Sudden jump in the last row. They'll thrown high. They'll come back, sit. That day, nothing will happen. Next day, they'll come with low backache. When you take a lateral view, exactly it shows a fracture like this. That's the history of wedge compression fracture. Wedge compression fracture is a harmless fracture. Since this is happening in the body, 100% this is not going to cause any neurological deficit. So, reassure the patient. Most of the time, my professor used to say, never ever or divulge the diagnosis. Don't tell the diagnosis. Just say some muscle sprain, muscle tear, something. Don't use the word fracture. Give him bed rest for 14 days. Give painkiller. He'll be all right. Okay, so there's such a harmless fracture. Wedge compression fracture, treatment of choice, conservative, nothing heroic. Okay, then comes the next fracture. Look at here. See, you are able to see this is a bone. Partial breakage of bone is there. This is the periosteum. Periosteum, there is a buckling. Okay, there is a swelling, buckling. Okay, so this is called a torus fracture. This is called a torus fracture, otherwise called buckling fracture. Okay, this is called a torus fracture, otherwise called a buckling fracture. Torus or buckling fracture. Look at the X-ray. That's a real X-ray of one of my patient. You see here, when it comes here, okay, in this place, a small buckling is there. Okay, so torus or buckling fracture. Torus or buckling fracture exclusively happens in a child before epiphyseal closure, exactly like your green stick fracture. This happens in a child before epiphyseal closure, and this is more common. I said green stick fracture more common in forearm bones. This torus or buckling fracture is more common in weight-bearing bone, especially tibia, lower tibia. That's the diagram. Okay, torus or buckling fracture. What is the treatment of choice? You see, this is again an incomplete fracture. Okay, don't do anything. Just put a POP slab. Just put a POP slab. In 28 days time, that will heal by its own. Okay, last but not the least, look at here. Easily you can make out the part. This is the head of the femur. This is the greater trochanter, lesser trochanter. This is the neck, and here a fracture has happened. So this is fracture neck of femur. Fracture neck of femur. The fracture has happened. A fracture has happened. This is the proximal fragment. The whole thing is the distal fragment. That is the proximal fragment. The whole thing is the distal fragment. Okay. So you see the proximal fragment got impacted to the distal fragment. So this fracture is called impacted fracture. This fracture is called impacted fracture. This is another atypical fracture, impacted fracture. If they ask in MCQ, what's the most common site of impacted fracture? This is the thing. Fracture neck of femur is the most common site. Neck of femur is the most common site. The second common site is lowermost portion of the tibia near to the ankle mortise. Impaction can happen. Fall from height. Jump from a height. Lowermost portion of tibia gets impacted to the ankle mortise, and that is called pylon fracture. That is called pylon fracture. These two are common sites for impacted fracture. Okay, so these, in short, we have completed what is a fracture, classification of fracture, typical, atypical. Under typical we had seen 5 types, under atypical we had seen this much type. So in just fractures, basics of fracture. With this we will move on to the next important topic, fracture clavicle. Fracture clavicle. Anatomical peculiarities of clavicle. Okay, clavis means key. Clavis is a word which is derived from clavicula, which means key. Okay, key means, don't think lock and key. Lock and key will be looking like this. Yes or no? This is how a key looks. But you see, this is an S-shaped bone. This doesn't look like a lock and key. Key here means musical key. Okay, musical key, musical symbol. Okay, it looks like a musical symbol. So okay, so this is like usually music directors used to write the notations like this, no? So they will be writing notations like this. Okay, various forms like this. So clavicle, it looks like that, like a musical symbol. So this is called, clavis means, key means musical key, not your lock and key. Very basic point. Okay, and 1 lakh time repeated question, first bone to ossify in the human body. When it starts ossifying, see, it has 2 ends, dear friends. This is the sternal end. This is the acromial end. Sternal end, acromial end. First end that starts ossifying is acromial end. Starts ossifying. First bone to start ossifying. Where? 5th week of intrauterine life. 5th week of intrauterine life. And this is the last bone to complete ossification. Okay. So the sternal part is the last end in the clavicle in the human body. Osteology to get completes its ossification. See how peculiar it is. This is the first bone to start ossifying. This is the last bone to complete its ossification. So the sternal ends is the last site in the human body to complete its ossification. That is by 25th year of life. This starts from 5th week. Okay. So the acromial end starts ossifying by 5th week. completes its ossification by 25 years of life. What a peculiar thing. All these things have been asked 1 lakh time in set. You just refer your thing. In anatomy they had asked, in ortho they had asked. And it ossifies. This is the only bone to ossify from 2 primary centers. Usually all the bones start ossifying by only one primary center. This starts by 2 primary centers. This is the only long bone to ossify from membrane. Because there are 2 types of ossification. One is called enchondral ossification, another is called membranous ossification. All long bones ossify enchondrally, all flat bones ossify membranously. The only long bone in the human body to ossify membranously is clavicle. 10 lakh times repeated MCQ. Then comes only long bone which does not have a medullary canal. How peculiar it is. You take any long bone, man. You take radius, ulna, you take humerus, you take femur, tibia, fibula, whatever long bone you take, there will be cortex, there will be medullary canal. Clavicle is the only long bone which does not have a medullary canal. And last but not the least, most common bone to be fractured in newborn. Most common fracture of birth trauma. Okay, birth trauma is clavicle. Okay, newborn. So that is why the most common bone to be fractured in a newborn is clavicle. Just I will revise for you. Already we had seen all the main videos. We had seen everything. Just we will revise. Most common bone to be fractured in a newborn, clavicle. Most common bone to be fractured in a child is supracondylar humerus. Most common bone to be fractured in elderly is collis. Most type of fractures, distal radius, collis. Okay. Most common fracture of newborn, clavicle. Most common type of fracture in childhood is supracondylar. Most common fracture of elderly is collis. Okay. Most common fracture of young adults, scaphoid. Most common fracture of young adults, scaphoid. 4 most commons I had told you just now. Most common fracture of a newborn, clavicle. Most common fracture of a childhood, supracondylar. Most common fracture of an young adult, scaphoid. Most common fracture of elderly, collis. You see the coincidence, man. All the fractures, most commons are happening in upper limb. You will never forget this point. Very good. So, what happens? What are the 2 deforming? Always fracture clavicle. There is a rule. Fracture clavicle, how will be the prognosis? Excellent. 100%? Yeah, 99% will unite when you treat conservatively. What's the problem? Malunion. All the cases will have minimal malunion. Why? The deforming forces are like that. There are 2 important deforming forces. When fracture clavicle happens, 2 forces which displaces the fragment. Medially, you see, this is medial fragment is displaced upwards by sternocleidomastoid muscle. Medially, this is displaced up by sternocleidomastoid muscle. The lateral half is pulled down by weight of the upper limb. Weight of the upper limb. The lateral half pulled down by weight of the upper limb. The medial portion, medial fragment is pulled up by sternocleidomastoid. So always it's going like that. So we are planning, we are giving a treatment, conservative management to neutralize both these forces so that it will unite. Okay. So if they ask in the exam, what are the deforming forces? This diagram should come to your mind. Medial 2/3 pulled up by sternocleidomastoid, lateral 1/3 pulled down by weight of the upper limb. Most common site of fracture clavicle, most common site, see the real osteology picture. Most common site is medial 2/3, lateral 1/3, junction. To my knowledge, most frequently asked MCQ in fracture clavicle is this. Most common site of fracture clavicle, medial 2/3, lateral 1/3, junction. Okay. We'll get on MCQ right. Very, very simple thing. Yes. And what is the X-ray view of choice? Normally in our OP, we will take X-ray AP view, anteroposterior view. That is okay view, but not an excellent view. The view of choice. In MCQ, they will always ask what's the view of choice. View of choice, just look at me. You concentrate me. You make the patient bend like this. Go for lordosis like this. Okay, for 45-degree lordosis. Keep the film here. Pass the beam from above. It will pierce the clavicle. The S-shaped bone, the full bone is seen very easily like this. Okay. So, this view is called 45-degree lordotic view. 45-degree lordotic view. That is the view of choice. Dear friends, this 45-degree lordotic view does not have any specific name. It is not a named view. Because some MCQ books are wrongly given, there is a word. I will tell that point also. I will tell the correct answer for that also. Striker. They had used the word striker's view. Striker's view is not this 45-degree lordotic view. Striker's view is the view of choice to see acromioclavicular joint. So whenever they ask in an MCQ, the best view to diagnose acromioclavicular joint pathology, acromioclavicular joint dislocation, the answer is Stryker's view. The best view to diagnose fracture clavicular clavicular pathology is 45-degree lordotic view. Okay. CT scan, is it useful? Very useful. If you have a case of fracture clavicle in the lateralmost end. See, look at this diagram. This is the normal site. 99% of fracture clavicle, 90% happens at this site. Suppose fracture happens at this site. CT scan is the best. X-ray is very good for medial 2/3, 1/3 junction. When it is near the acromioclavicular joint, CT scan is the best investigation, because only CT scan will give you a picture whether the fracture has an intra-articular extension. Whether the fracture has an intra-articular extension. So CT scan is very useful in the lateral third fractures, especially when you suspect intra-articular extension. Okay? Yes. That's the investigation. Then classification names. Nowadays it's a trend. The past 5 years, dear friends, all the fractures are asked, they are asking only classification name. Don't forget, already in the main video I had highlighted everything. Very simple. This is called Allman and Craig classification. Very simple. Type 1, type 2, type 3. Okay, so this is type 3. Okay, this is type 3. This is type 2. This is type 1. So, type 1 means middle third, that is medial 2/3, lateral 1/3 junction, 80%. This is the most common type. The second common type is type 2, that is lateral third fractures, 15%, second common type. Least common type is type 3, that is the medial third, near the sternoclavicular joint, end, sternal end. This constitutes only 5%. I had never seen a case so far. Whenever a case comes, to my practical knowledge, this book says 80%. I am telling practically from my 20 years of orthopedic experience, 90% it is only type 1. Allman's type 1. Allman and Craig's classification. Okay. This you can expect in your MCQ. Most common type of clavicular fracture, Allman and Craig's type 1. What is the site? Medial 2/3, lateral 1/3 junction. What is the, how many percentage? 80%. Yes. Coming to treatment options, you can treat either conservatively or you can treat surgically. I am telling you, 99% of fracture clavicle treatment of choice is conservative. Treatment of choice is conservative. So treatment of choice for 99% of fracture clavicle is conservative. What treatment you are giving, what conservative management you are giving, just focus your attention on me. We had seen two deforming forces, yes or no? Two deforming forces. Lateral 1/3 pulled down by weight of your upper limb, medial 2/3 pulled up by sternocleidomastoid. So there is a, what I can say, there is a deviation, there is a displacement, that's the right word. There's a displacement. Lateral 1/3 pulled down, medial 2/3 pulled up. There is a displacement of both the medial and lateral fragments. These are the deforming forces. Now I have to immobilize in a position and I should neutralize both these deforming forces. How to do that? Medial 2/3 pull by sternocleidomastoid is managed by giving a figure of 8 bandage. By a figure of 8 bandage. Figure of 8 bandage. Okay, you would have seen, no? So people know with now ready-madely available figure of 8 is available with a cushion. You put a bandage like this. It will go cross like this. So that's called a, so when you see the bandage, no, it will go to the opposite shoulder, it will be cross like this. So this is called a figure of 8 bandage. Lateral 1/3 pulling down, that force, that deforming force is neutralized by giving an arm sling. Okay, give an arm sling with figure of 8. So combination of figure of 8 with an arm sling. Arm sling is otherwise called cuff and collar. This will solve 99% problem of fracture clavicle. So patient is immobilized with a figure of 8 plus an arm sling for 45 days. Fracture clavicle will unite beautifully. Minimal malunion is there, no problem with malunion, because already the bone is not a uniform bone, man. It is little projected. It causes little malunion. What's going to happen? Nothing. Nobody can notice anything. Since it's a membranous, it ossifies membranously, a membranous bone, callus formation will be excellent. Healing will be excellent. Okay. So, yes. And this is the treatment of choice. When will you do surgery? The surgical indications for fracture clavicle. Okay. What are the indications for surgery in fracture clavicle? Only 1% needs surgery. The first indication for fracture clavicle is a compound fracture. Okay. First indication for surgery, compound fracture. Compound fracture means open fracture. There is a wound here. How can you put a figure of 8? You have to do some fixation. So compound fracture. Number 2, you had tried conservative management. Even after 3 months, the fracture is not uniting. It has gone for non-union. Whenever, anywhere in the human body, in the bone, non-union has happened, the only treatment that is left is open reduction internal fixation with a bone grafting. So non-union. The third indication for surgery in a fracture clavicle is associated neurovascular injury. Neurovascular compromise is there. What are the vessels that can get damaged in fracture clavicle? Subclavian artery, subclavian vein. What is the nerve? Medial cord of brachial plexus. So whenever fracture clavicle is associated with a subclavian injury or a medial cord of brachial plexus injury, immediately it should be opened and explored. Otherwise, it will go for permanent thing. So third, associated neurovascular. Number 4, associated, okay, fracture rib and fracture scapula. Whenever there is associated fracture rib and fracture scapula, see, the most common mechanism of fracture clavicle is fall onto the same side shoulder. So sometimes fracture clavicle happens. Sometimes associated rib fracture can happen, associated scapula fracture can happen. Whenever there is an associated rib and scapula fracture, how can you give figure of 8? Won't it hurt the patient? Definitely. So figure of 8 you can't give. So there you have to do some plating surgery. And 5th indication, when fracture is near AC joint, fracture is near acromioclavicular joint. Your figure of 8, that's lateral most end, the fracture is there. You can't give figure of 8, that will displace the fracture more and it needs fixation. So only 5 indications are there for fracture clavicle, surgical indications for fracture clavicle. Number 1, if it's a compound fracture. Number 2, non-union. Number 3, associated neurovascular. Number 4, it is associated rib and scapula fracture. Number 5, when its fracture is near the AC joint, acromioclavicular joint. This is the most favorite initiate question in fracture clavicle. Fracture clavicle, there are several times AIMS, they had asked, all are indications for surgery in fracture clavicle except. Okay, very simple, 5 indications. And 6th, they had given in one Indian book. So these are from Campbell's. 6th indication, if it is bilateral fracture clavicle, you have to fix it. How can you give a figure of 8 for that? It's not possible. Very hurting. Okay. Yes. Now, coming to the last point in fracture clavicle, what are the complications of fracture clavicle? Most common complication, I told you, 100%, it is malunion. 100% case will go for malunion, but it is not a troublesome complication. It's not going to affect the joint movement, nothing. And most common vessel that is injured is subclavian artery and subclavian vein. Most common nerve injured is medial cord of brachial plexus. Medial cord of brachial plexus means it's a broad thing. Medial cord of brachial plexus can be medial pectoral nerve, medial root of median nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm, ulnar nerve. 5 nerves are there in medial cord of brachial plexus. So for an MCQ, you can't, Viva you can manage, sir, medial cord of brachial plexus, sir. No, MCQ, no, a machine is correcting, a computer is correcting. He will be very pinpoint. Among the 5 nerves of medial cord, which is the most common nerve? The answer I will give you directly from Campbell, dear friends, ulnar nerve. Please note this point, ulnar nerve. Okay, in UG books, this point is not stressed. That's why I am stressing ulnar nerve. And most common associated fracture, already I told you, rib and scapula fracture. And fracture clavicle is one of the cause for thoracic outlet syndrome. Thoracic outlet syndrome. That completes fracture clavicle. We will move on to the next topic, shoulder dislocation. We'll move on to the next topic, shoulder dislocation. Shoulder dislocation, the book says there are 65 major joints in the human body. Most common joint to undergo dislocation is shoulder. There are 65 major joints in human body. Most common joint to undergo dislocation is shoulder. Okay, with this introduction, the commonest dislocation of human body, shoulder dislocation. There are 3 types of shoulder dislocation. This is called anterior shoulder dislocation. This is called posterior shoulder dislocation. This is called inferior shoulder dislocation. This is called inferior shoulder dislocation. Okay. See, you see anterior shoulder dislocation. We all know, just you please focus on me. Just look at me. Shoulder joint is a ball and socket type of joint. Ball is head of the humerus, socket is your glenoid cavity. When the ball gets slipped from the glenoid cavity, it is lying in front of glenoid, that is called anterior. That is otherwise called preglenoid. In front of glenoid, preglenoid, anterior shoulder dislocation. When the head of humerus is just behind the glenoid cavity, it is called posterior shoulder dislocation. Other way around, what happens, the head of humerus is inferior to the glenoid cavity. Since it's inferior, what happens? The shaft of humerus will go like this. That is why in this picture, you see this inferior. In this picture, you see, this is the glenoid cavity. This is head of humerus. The shaft is going like in this direction. It's upwards like this. So this is called, this has a peculiar name, luxatio erecta. Luxatio erecta. Luxatio erecta, which is getting erected. Shaft of humerus getting erected. So it's called luxatio erecta. So among the 3, most common type is anterior. Second common type is posterior. Least common type is inferior. Whenever a case comes to 99%, it will be anterior shoulder dislocation. Coming to the attitude, no, whenever it's an anterior shoulder dislocation, the arm lies close to the body. The arm is extended, externally rotated, and it is extended. Okay. See, this is the attitude of anterior shoulder dislocation. The arm lies by side of the body. Arm is extended and externally rotated like this. When you ask the patient to touch the opposite shoulder, patient can't touch the opposite. See, I am able to touch the opposite shoulder easily. So when it is dislocated, anterior shoulder dislocation, patient can't touch the opposite shoulder, and that is called Dugas test. Okay. So this is the attitude. Just when a patient is entering your OP, just by looking at the attitude, you can say, without X-ray, you can say what type of shoulder dislocation is that. The arm is extended, abducted, externally rotated. Arm is extended, slightly abducted, externally rotated. It is anterior shoulder dislocation. Patient is coming, it's looking near normal. You are not seeing any change in the attitude. It should be posterior dislocation. When the arm is hyperabducted, patient is coming like this. Because in inferior, what happens? The shaft of the humerus is erected. So then it is inferior shoulder dislocation. Patient is coming like this. This is inferior shoulder dislocation. Other is called luxatio erecta. Very simple. Yes. And what are the clinical signs of shoulder dislocation? There is loss of roundness of the shoulder. The deltoid contour is lost because ball has slipped out of the socket. Flat deltoid. The loss of absence of roundness of shoulder is the first sign. Shoulder is extended, slightly abducted, externally rotated. That is the attitude. That is the second sign. Patient is not able to touch the opposite shoulder. That's called Dugas test. When you take a ruler, when you keep like this, because the deltoid becomes flat, the ruler flushes with the skin. There is no palpable that gap in the upper end and over the lateral epicondyle. Everything is flushed together. That is called Hamilton ruler's test. For detailed explanation, see the main video. Then take an inch tape, measure the girth or width of the axilla. In the dislocated side, the girth or width of axilla is more than the normal side. That is called Callaway's test. Okay, third test. Hamilton fourth, Callaway fifth. Okay, Bryan's sign. Normally we will have anterior axillary fold on both sides. If there is anterior shoulder dislocation on the affected side, the anterior axillary fold is pushed down. That is called Bryan's test, sixth type. And whenever you touch for sensation over the deltoid on the affected side, on the dislocated side, if axillary nerve is compressed, the sensation is diminished over the deltoid, and that is called regimen batch test. Okay, so seventh test. So what are the 7 classical signs of shoulder dislocation? Absence of roundness of shoulder, attitude of extension, abduction, external rotation, positive Dugas, positive Hamilton ruler, positive Callaway, positive Bryan's, positive regimen batch. Coming to X-ray, when you take an X-ray, classical named X-ray signs are there only for posterior shoulder dislocation. 2 signs I had written here. Both the signs are only for posterior shoulder dislocation. There is no named sign for anterior shoulder dislocation. If it is a posterior shoulder dislocation, what you can see, the head of humerus just slipped out of the socket, glenoid cavity, and the glenoid cavity is seen empty. Very clear rim of glenoid cavity is seen, and that is called a vacant glenoid sign or empty glenoid sign. Okay. Number 2, in posterior shoulder dislocation, the head of humerus gets dislocated. You see, totally get dislocated and turns like this. The head exactly looks like the old Philips 40 watts bulb. So this is called a daylight sign. Otherwise, our Indian books uses the word light bulb sign. Both are one and the same. Both have been asked in the entrance. Daylight sign, other is called a light bulb sign. Look at here. Exactly the outline looks like a 40 watts Philips bulb. So it's called a light bulb sign. Okay, so a vacant glenoid sign and a light bulb sign or a daylight sign, these 2 are named signs for posterior shoulder dislocation. There is no named sign for anterior shoulder dislocation. Right. Coming to, you should know 2 important lesions in shoulder dislocation. So one is called Bancourt's lesion, another is called Hill-Sachs lesion. Bancourt's lesion is a soft tissue lesion. Hill-Sachs lesion is a bony lesion. Basic point. Bancourt's lesion is a soft tissue lesion. Hill-Sachs lesion is a bony lesion. Bancourt's lesion, there is damage in the anteroinferior portion of the, okay, so it is, Bancourt's lesion is, there is damage in the anteroinferior aspect of the capsule and the labrum. In Bancourt's lesion, there is damage to the anterior structures, anteroinferior aspect of the structures. What are the 2 structures that are damaged anteroinferiorly? The capsule and the labrum. Capsule and the labrum. Bancourt's soft tissue injury in the anteroinferior aspect of the capsule and the labrum. Okay. Bancourt's anteroinferior. Boy, a mnemonic is coming. Hill-Sachs lesion is a bony lesion. I said, where is that? You look at this diagram. A beautiful real bone, autopsy pathology. Are you able to see a dimple, a depression here, a dimple here? You see, without this, you can see very clearly a dimple. Okay, so where it has happened? Posterolateral aspect of head of humerus, there is a depression. There is a defect. There is a defect in posterolateral aspect of head of the humerus. So Hill-Sachs lesion, posterolateral. Why I am giving this BOY and HPL, Hewlett Packard Limited, a computer company name, HPL, we can't forget. BOY, B-I, BOY. Okay, so BOY and HPL. Why I am telling? Several times asked Ames question, dear friends, what is Bancourt's anteroinferior, superior, posterior, posteromedial? They will confuse you. No confusion. Bancourt's anteroinferior, BOY. Hill-Sachs posterolateral. Bancourt's soft tissue, Hill-Sachs bony. Okay, so Hill-Sachs is posterolateral defect in head of the humerus. So don't forget these 2 mnemonics. And then What do you mean by terrible triad of shoulder? Once you know these two lesions, terrible triad is a child's play. Terrible triad means three things are there. 1, 2, 3. Okay, three things are there. One is Bankhart's, 2 is Hill-Sachs, 3 is erosion of the anterior glenoid rim. Okay, the Bankhart's lesion, a Hill-Sachs lesion, erosion of the anterior glenoid rim. Suppose in a shoulder dislocation case, when the same side shoulder has these three pathologies together, Bankhart's lesion plus Hill-Sachs lesion plus erosion of anterior glenoid rim, this combination is called an unhappy triad, otherwise called a terrible triad. Why? Once they develop these lesions together in the same side shoulder, that will go for the next important complication, recurrent shoulder dislocation. Simple shoulder dislocation will become recurrent shoulder dislocation. Once recurrent shoulder dislocation has happened, it is problematic for the patient, it is problematic for the surgeon. So the word used is unhappy triad. Okay, good. Then coming to treatment of shoulder dislocation. Treatment of shoulder dislocation, the treatment of choice is called Koch's method. Koch's method is the treatment of choice. It needs two persons. Put the patient lie down in a supine position. Okay, so I'm giving traction, somebody is giving counter traction here. So I'm giving traction, external rotation, adduction, medial rotation. So what are the 4 steps? Traction, external rotation, adduction, medial rotation. TEAM. Traction, external rotation, adduction, medial rotation. Team technique. Okay, that is the treatment of choice. The other two methods that were followed previously was called Stimson's gravity method, Hippocrates method of historical importance. Okay, now surgeries for when recurrent shoulder dislocation, certain names they are asking. In image based session, I will highlight that. Bankhart's operation, Putty plots, Bristow. These 3 names you remember. Coming to complications of shoulder dislocation, most common nerve that is damaged is axillary nerve. Most common artery that is damaged is axillary artery. And recurrent dislocation is an important complication. Most common joint to undergo recurrent dislocation is also shoulder. I told you the most common joint to undergo dislocation is shoulder. The most common joint to undergo recurrent dislocation is also shoulder. That completes the topic, shoulder dislocation. We will move on with the next topic, supracondylar fracture. What are the points? Most common fracture in childhood. Most common age is 5 to 8 years. Most common in boys. Most common on left side. All these 4 points have been asked several times. What are the reasons why supracondylar fracture is very common between 5 to 8 years? Why it is very common less than 10 years in a child? 5 reasons are there. Please go through. Okay, in detailed discussion we had already done. The 3 classical deformities of supracondylar fracture, the mnemonic goes by the word DIM. Dorsal displacement, impaction, medial tilt. Dorsal displacement is otherwise called extension. Impaction is otherwise called proximal migration. Medial tilt is otherwise called pronation. So you just remember dorsal displacement, impaction, medial tilt, DIM. These are the 3 classical displacements of supracondylar fracture. Guaranteed question. Okay, DIM. Right. What are the 2 types of supracondylar fracture? The first type is called extension type, which is 98% most common type. The rare type is called flexion type, otherwise constitute only 2%. This extension and flexion depends upon the position of the distal fragment. When distal fragment is displaced behind in extension, it's called extension. Towards the anterior side, it's called flexion. So the most common type it is extension. Okay. This extension type is further divided into posteromedial displacement of the distal fragment, posterolateral displacement of the distal fragment. Most common type, see dear friends, there is a catch point here. That's why with the thing I am explaining. Posteromedial type is the most common type, 80%. Okay. When posteromedial type happens, the nerve that is damaged is radial. Posterolateral type is only 20% of the extension type. You all know the supracondylar fracture is divided into extension type, flexion type. Extension type is the most common type. Extension type is subdivided into posteromedial, posterolateral. When there is posteromedial displacement, it goes and hinges the radial nerve, so radial nerve may get damaged. If it is posterolateral, it may go and hinge the anterior interosseous nerve. Anterior interosseous nerve, you know pretty well, which is a branch of median nerve. So that may get damaged. The catch point is, posterolateral type is associated with more nerve injury than posteromedial type. So, anterior interosseous nerve is the commonest nerve injured in supracondylar fracture. 10 lakh times repeated MCQ. Most common nerve that is damaged in supracondylar fracture is anterior interosseous nerve, which is a branch of median nerve. Okay, right. The classification system we had seen for clavicle fracture, Allman classification, like that, it's called Gartland classification. Gartland classification, type 1, type 2, type 3, very simple. Type 1, undisplaced, just a crack, hairline crack is there, undisplaced. Type 2, displaced with intact posterior cortex. Type 3, completely displaced. Type 1, undisplaced. Type 2, partially displaced. That is, posterior cortex should be intact. Type 3, completely displaced, totally displaced. Now you see the diagram. With this. You see type 1, just a hairline. This is a lateral view. Just a hairline crack is there. No displacement. Type 2, displacement is there anteriorly, but the posterior cortex is intact. So this is type 2. Type 3, totally displaced. So type 1 undisplaced, type 2 partially displaced with intact posterior cortex, type 3 completely displaced. Okay, so this is called Gartland classification. Only when we know the classification, we can plan for the management. And what are the clinical signs of supracondylar fracture? Just make the baby sit down in a stool, expose the dress, just see the arm. Arm will be having an S-shaped arm, because you know the proximal fragment is displaced anteriorly, the distal fragment is displaced posteriorly. That's called extension type. So when you see the arm, it will be S-shaped. Number 1 sign. Number 2 sign, when you just have a look at the skin over the fracture site, there will be puckering of skin like a dimple. So that's called a dimple sign. Then when you palpate, the fracture is supracondylar. That means the fracture is above the medial and lateral epicondyle. So you palpate the lateral epicondyle, palpate the medial epicondyle, olecranon. The 3 bony points, the triangle is well maintained. The isosceles triangle is well maintained. The lateral epicondyle, medial epicondyle, olecranon. The triangle is well maintained because the pathology is above both the epicondyles. So why they are stressing this point? 3 bony prominences not disturbed, 3 bony prominences maintained. Why? Because only by this method you can differentiate whether this is a dislocation elbow or supracondylar fracture. In supracondylar fracture, the 3 bony points are well maintained. In elbow dislocation, the 3 bony points are disturbed. Okay, very simple. Coming to X-ray signs, now image-based MCQs in INISET and NEET and next exams. This is very important. Classical fat pad sign, classical teardrop sign. Teardrop sign is a normal sign in lateral view of humerus in a child. The teardrop sign is disturbed. 3rd, fishtail sign. 4th, crescent sign. We cannot leave a single thing. So number 1, fat pad sign. Number 2, normal teardrop sign is disturbed. Number 3, fishtail sign. Number 4, crescent sign. One by one, I will show you in the diagram. Just let us see fat pad sign. The lateral view, this is the shaft of the humerus. You have to see, this is the ulna, this is the radius. See, this is an immature skeleton. Epiphysis is not closed. The lateral view in the X-ray, you can see, this is the triceps muscle. Posterior, the fat, slightly raised like this. You are able to see. Okay, a gap will be there. This is called posterior fat pad sign. Just in front of the fracture, here you can see a gas-like shadow. This is a raised anterior fat pad sign. So here is the fracture. Able to see the fracture here. This is the fracture. Okay, so this is anterior fat pad sign. This is posterior fat pad sign. So this is called fat pad sign. So, dear friends, you should know one thing. X-ray, definitely it will show you very clearly the bone. A good X-ray, a good orthopedician's eye will see soft tissue also in an X-ray. Okay, so here comes the posterior and anterior fat pad sign. Then comes the classical teardrop sign. You look at this is the lateral view. This is a schematic diagram. This is a real X-ray. Compare both. This is a normal X-ray. You see, you are able to see this is lateral view. When you see here, this part, no, you can see like a teardrop. You can see like a teardrop. So this is a diagram. This is a diagram. You see this real X-ray, lateral view. One of our patient's X-ray. You see here. See. Are you able to see a teardrop like thing? So this is normal. When there is a fracture, this fracture line will go like this, and the normal teardrop is disturbed. Normal teardrop is disturbed. Look at here. You focus here, the lateral view. Able to see here the lateral view. I'm able to see a small teardrop like thing. And when you focus, no, you zoom and see. Okay, you can see a fracture line going through this teardrop. So the normal teardrop sign is disturbed. That's the second radiological sign. Third thing, this is the proximal fragment. This is the distal fragment. Distal fragment is extended. So extension type proximal fragment is so able to see an S-shaped arm. See, S-shaped arm. In the proximal fragment, when you see, no, the end of the fragment is serrated. It's like this. Serrated. It's like this. The end of the proximal fragment. You compare that with a fish tail. Is it not looking like that? So this is called a fish tail sign. This is called a fish tail sign, right? And then comes the crescent sign. You should know what is the crescent sign. Crescent sign, the normal radiolucent gap of the elbow joint is missing and a crescent shaped opacity is seen due to overlap of the capitulum over the olecranon. This is called the crescent sign. Okay, that's called the crescent sign. Okay, you are able to see, no, here this, okay, crescent sign. Then coming to treatment of supracondylar fracture, once you know all the names in the radiological features of supracondylar fracture, treatment is very simple. According to Gottland's classification, type 1, type 2, type 3. Okay, 3 types are there, type 1, type 2, type 3. Type 1, totally undisplaced. Treatment of choice is just immobilization in 110-degree flexion. Immobilization with a long arm cast is the treatment of choice. That's called conservative. Type 2, partial displacement. That means the posterior cortex is intact, anterior cortex is broken. So, just again, what happened? Type 2, closed reduction. Just with anesthesia, just reduce and put a percutaneous K-wire. Percutaneous, through the skin, put a K-wire through C-arm guidance. That's the treatment of choice. Type 2, because it's partially displaced. Type 3, open reduction, internal fixation with the K-wire. Because since it's totally displaced, you have to split open the triceps, go align it properly, fix it with a cross K-wire. Cross K-wire, that is the treatment of choice. So type 1, immobilization in long arm cast in 110-degree flexion. Type 2, closed reduction, internal fixation with percutaneous K-wire. Type 3, open reduction, internal fixation with K-wire. That's all. Okay. Alright. So the complications of supracondylar fracture, most common nerve that is involved is anterior interosseous nerve. That's the most common. Most common vessel that is injured is brachial. Most common late complication is malunion. This malunion is called cubitus varus deformity. This is called cubitus varus deformity. Otherwise called gunstock deformity. Gunstock. If they ask a question, most common late complication is malunion. Gunstock deformity, otherwise called cubitus varus. And this is supracondylar fracture is notorious to cause compartment syndrome, otherwise called Volkmann's ischemia. And supracondylar fracture, what happens? No, when you just give when they go to traditional bone setters, it may cause myositis ossificans. So these 5 are important complications of supracondylar fracture. This classically look at this gunstock deformity, exactly cubitus varus, which looks like exactly like a gunstock. So it's called a gunstock deformity, right? And the posteromedial displacement, the reason for your cubitus varus is posteromedial displacement. Gunstock deformity is not involving the growth plate, so it's a static deformity. This question they had asked several times. Okay, there are two types of deformity: static, progressive. When a deformity, when it involves growth plate, the deformity can be progressive. Lateral condyle fractures of humerus, progressive deformity. Okay, whereas supracondylar fracture is not involving the growth plate, so it's a static deformity. Deformity will be there, it will be static, it won't progress. Okay, three static deformities which causes cubitus varus. Again asks the question: extension, medial rotation, varus. When the extension, the distal fragment, medial rotation of the distal fragment, varus of the distal fragment, when they are not corrected properly, will end up in gunstock deformity. What is Metov sign? This is a extra edge question for INICET guys. Okay, Metov sign, METEV. What is Metov sign? It is a radiological sign. First point, it's a radiological sign. If in the case of supracondylar fracture, okay, when they give some massage or something, myositis ossificans has developed. What happened? No, myositis mass will give a radio opaque shadow in the X-ray. When you take an X-ray, it will go a radio opacity. Inside the opacity, you can see a small hole-like thing. Small hole-like thing. That hole is because that myositis mass is being traversed by median nerve. Okay. Median nerve, when it traverses the myositis mass, median nerve is seen transparently. You can't see that in X-ray. So inside a radio opaque structure, you are seeing a hole-like thing. Okay, a small hole-like thing. That hole is because that myositis mass is being pierced by the median nerve. This hole-like thing which you are seeing in a radio opaque mass is called Metov sign in X-ray. It's a very, very classical radiological sign, Metov sign. What is Holstein-Lewis fracture? Holstein-Lewis fracture, if it is a fracture in the distal third shaft of humerus, and usually an oblique type or spiral type, with the distal end deviating towards the radial side, very high chance this will go and damage the radial nerve, and it will present to you with radial nerve palsy, wrist drop. Look at the diagram. Distal third shaft of radius fracture. The distal fragment is displaced radially, causing the damage to the radial nerve, will present to you with a wrist drop. So that is called Holstein-Lewis fracture. It's a named fracture, very important fracture as far as this the MCQ angle. What is Holstein-Lewis? Distal third oblique fracture of the humeral shaft, causing radial nerve palsy. That's called Holstein-Lewis fracture. And book says this is an orthopedic emergency. Immediately it should be explored. Radial nerve should be decompressed. Otherwise it will go for permanent wrist drop. Okay. Yes. Coming to the next chapter, elbow dislocation. Elbow dislocation, the first point, most common joint to be dislocated in a child elbow. Dear friends, most common joint to be dislocated in general, shoulder. If they specifically ask a question, most common joint to be dislocated in a child, and elbow dislocation is in the choice, that is the answer. Okay. This is a hook. They may keep a hook. Okay. So, dear guys, fish may go and get caught in a hook. Okay, not our guys. We know how to escape. Right? So I repeat once again, most common joint to be dislocated in general, shoulder. Most common joint dislocated in a child means elbow. Okay. Posterior dislocation of elbow is the most common type. Clinical feature, short forearm with three bony relationship disturbed. See, when elbow dislocation happens, you see this is the humerus, this is the ulna. Okay, you know this is the olecranon fossa, this is ulna. Okay, this is ulna. Ulna got dislocated, humerus is here, and ulna is pushed posteriorly, pushed back posteriorly. So what happens on the affected side? The forearm appears shorter. Forearm appears shorter. Okay, and what happens when you see here? the triceps tendon stands out prominently, and that is called bowstring sign. That is called bowstring sign. Bowstring sign. What is the classical sign of elbow dislocation? Because the ulna, ulna is pushed posteriorly, triceps got relaxed. So the triceps tendon stands out prominently like a bow and arrow bow. So that's called a bowstring sign. That's called you can do like this, called a bowstring sign. Yes. And what happened to the three bony prominences? Already I mentioned this in supracondylar fracture. You see, this is a supracondylar fracture. Medial epicondyle, lateral epicondyle, tip of the olecranon. The triangle is well maintained because pathology is above. But here in elbow dislocation, what happened? Pathology is in the joint. So the isosceles triangle is disturbed. It's not maintained. Okay, right. Look at this. The most common type of elbow dislocation is posterior. Anterior is very rare. What are the components of terrible triad? A terrible triad of shoulder we had seen. This is called terrible triad of elbow. What are the three components? Number one, elbow dislocation. Elbow dislocation. Number two, radial head fracture. Radial head fracture. Number three, coronoid fracture. Coronoid fracture. So in an individual, in the same elbow at the same time, elbow dislocation plus radial head fracture plus coronoid fracture happens. This is called unhappy triad or terrible triad of elbow. Why? When these three things happen to the same elbow at the same time, elbow will become a floating elbow, unstable elbow. Okay, so it's called a terrible triad of elbow, other is called unhappy triad of elbow. Goes by a name. This triad is called Hotchkiss triad. Hotchkiss triad. Hotchkiss triad. Shoulder terrible triad does not have any name. Elbow terrible triad has a name, that's called Hotchkiss triad. The expected question, never need. Okay, so Hotchkiss triad is a terrible triad of the elbow. This is a very bad triad. It will go for unstable elbow. Treatment is very difficult. If it is simple elbow dislocation, reduction under general anesthesia, above elbow POP slab for 3 weeks is the treatment of choice. Most common vessel that is injured is brachial artery. Most common nerve that is damaged in elbow dislocation is directly the median nerve. The difference, dear friends, most common nerve that is damaged with supracondylar fracture is anterior interosseous branch of median. Most common nerve that is damaged in elbow dislocation is directly the median nerve. Okay, that's the difference. Then we'll go to what is called the pulled elbow. Pulled elbow is otherwise called nursemaid elbow. This is otherwise called nursemaid elbow. In an extended and pronated forearm, in an extended and pronated forearm, when the elbow is pulled, radial head gets subluxated from the annular ligament, and that is called pulled elbow. The only question in this topic asked for the past 15 years, the age group 1 to 4. 1 to 4. Rare after 5 years. Okay, yes. And please remember this crital mnemonic, age of appearance of epiphyseal centers around the elbow. This you can expect in anatomy, orthopedics, forensic medicine. This goes by a name called crital mnemonic. C stands for capitulum, R stands for radial head, E stands for epicondyle medial, T stands for trochlea, O stands for olecranon, L stands for lateral epicondyle. Cretol, C-R-E-T-O-L. Look at this mnemonic. Don't forget this golden mnemonic. Okay, capitulum, radial head, epicondyle medial, trochlea, olecranon, lateral epicondyle. 2, 4, 6, 8, 10, 12. Even numbers. Age of appearance of epiphyseal centers. I'll tell you a secret, friends. This question was asked when I was appearing for my MS Ortho exam. I wrote this mnemonic. I recollected, which fetched me a master degree. Okay, so this time honor for 15 years. They're asking this in ortho, forensic medicine, anatomy. Okay, crital mnemonics. Yes. Okay, we'll move on to the next important topic, Monteggia fracture. Several times asked question in NEET. The main important thing what we should know is the definition of Monteggia fracture. What is Monteggia fracture? Monteggia fracture is defined as fracture upper third ulna with radial head dislocation. What is Monteggia fracture? Fracture upper third ulna with radial head dislocation. Okay, so this is called Montegia's fracture. Montegia's fracture is otherwise called treacherous fracture. Treacherous means cheating. Treacher means cheater, traitor. Treacherous fracture. Why? Because fracture ulna is easily noticeable. Many a times we will miss the radial head subluxation or radial head dislocation. So that will cheat us. So it's called a cheating fracture or treacherous fracture. The most common mechanism is fall on outstretched hand, especially in hyperpronation injury. This is what they will ask in exam. Montegia's fracture is due to hyperextension, hyperpronation, hypersupination, hypopronation, something like that. So it's a hyperpronation type of fall on outstretched hand. So this is supination, this is pronation, hyperpronation, fall on outstretched hand. Most common mechanism. Montegia fracture, generally speaking, when compared with adults, it's more common in children. The classification system of Montegia is called Badow's classification. There are 4 types. I want you to remember one type. Type 1 is called extension type. This is the most common type. Okay, this is the most common type. Anterior, what do you mean by extension type? Badow's type 1 or extension type? Fracture angle is anterior. Radial head subluxation is also anterior. Fracture angulation is anterior. Radial head subluxation is also anterior. That is called extension type, otherwise called type 1. This is the most common type. The classification is called Badow's. Most common nerve that is involved or injured in case of Montegia's fracture is posterior interosseous nerve. Should be very careful. Most common nerve that is involved in supracondylar fracture is anterior interosseous nerve. Most common nerve that is involved in Montegia's fracture is posterior interosseous nerve. You know, posterior interosseous nerve is a branch of radial nerve. Anterior interosseous nerve is a branch of median nerve. Okay, right? And one thing you should know, McLaulin's line. When you follow this McLaulin's line in X-ray, we will never miss a Montegia fracture, and Montegia fracture no more can cheat us. McLaulin's line. What do you mean by that? A straight line drawn along the center of shaft of the radius goes and cuts the capitulum irrespective of position of the elbow. Elbow is flexed or extended, doesn't matter. When you draw a straight line in middle shaft of the radius, goes and it cuts the capitulum directly. If it is not cutting the capitulum, it says radial head is subluxated. So this is called McLaulin's line. And treatment of Montegia's fracture. In children, you can try closed reduction and above elbow POP slab. In adults, open reduction with plate and screws. So treatment is both conservative and surgical. In a child, we are treating conservatively. In an adult, we are treating it with surgical management. And the complications of Montegia fracture is unreduced dislocation of the radial head. When you miss this, this will go for an unreduced, neglected radial head dislocation. So pronation, supination may be affected in the future. Posterior interosseous nerve palsy. This can present as wrist drop, no? So posterior interosseous nerve palsy, malunion of the ulna, non-union of the ulna, cubitus valgus. They have not asked this question so far. Montegia, what type of deformity? Because of malunion of the ulna, it can cause cubitus valgus deformity. Radio-ulnar synostosis. What do you mean by radio-ulnar synostosis? Radius and ulna will join together because ulna fracture has happened, radial dislocation has happened. Radius and ulna may get fused in the proximal part. So it's called radio-ulnar synostosis. And obviously, any injury around the elbow joint, myositis ossificans. Okay. I'm having a slide of myositis, and while doing that, I will explain what is myositis ossificans. And coming to the next, the contemporary fracture and forearm fractures. Once you know Montegia, you should know Galeazzi. Galeazzi fracture is otherwise called Piedmont fracture, otherwise called fracture of necessity, reverse Montegia. What is Galeazzi fracture? Exact opposite of Montegia. What is Montegia? It is proximal ulnar fracture with radial head dislocation. Galeazzi fracture is fracture distal third radius with distal radio-ulnar subluxation. What is Montegia? Proximal ulnar fracture with radial head dislocation. Galeacy is distal radial fracture with distal radioulnar subluxation. See, this is Monteggia. Proximal ulna with radial head subluxation. Monteggia's fracture. Distal radius with distal radioulnar subluxation is Galeacy fracture. Okay. So, this is the difference. So, very, very important. They will see in image-based question, just they will give this image. Diagnosis, please. Very simple. You see, this is the lower third of the radius is involved. Distal radioulnar subluxation has happened here. So, this is a classical case of Galeacy fracture. This is a classical case of Galeacy fracture. And the book says it is 3 times more common than Monteggia. So, Monteggia is common or Galeacy is common? If they ask a question, Galeacy is more common than Monteggia. And overall, Monteggia is more common in children, Galeacy is more common in adults. Very simple. And what are the clinical features? Prominence and tenderness of the lower end of ulna is main feature. What is the classical sign called? Please listen to me. Look at me. What is happening in Galeacy? The lower third radius is gone, radial fracture. Distal radioulnar joint is gone. So, in this position, normally when I press the ulnar styloid, nothing is happening because my distal radioulnar joint is intact. If my distal radioulnar joint is disrupted, when I press the ulna, distal ulna, it will go down. When I leave it, it will come up. When I press it will go down. When I leave it, it will come up. Like a keyboard key. Keyboard, no? When I press the key, it will go down. When you leave it, it will come up. So, this is called the keyboard key, otherwise piano key. So, this is called piano key sign. The classical sign is called piano key sign. This is called a piano key sign. The classical sign of Galeacy is called a piano key sign. Okay. And coming to treatment, dear friends, the gold standard treatment, the only treatment that is available is surgery. No conservative management for Galeacy fracture. Because Galeacy is lower third radius fracture with distal radioulnar subluxation. Radius fracture, because a lot of muscle attachments are there in the radius. Radius is a deep bone. You have superficial compartment of muscles, deep compartment of muscles. So, definitely that will go for non-union. And distal radioulnar joint disruption has to be addressed surgically. So, 100% surgery is necessary for Galeacy fracture. So, it is called fracture of necessity. I told you it has one more name, fracture of necessity. Why it's called fracture of necessity? 100% surgery is necessary. So, it's called fracture of necessity. Okay. So, don't try conservative. Look at this diagram. Just this radius fracture, we had done a plating. Distal radioulnar subluxation, just we maintain that, fix it with a K-wire, cross K-wire. So, 2 things we have to do for Galeacy. Fracture has to be fixed with a long plate and screw, and distal radioulnar joint should be stabilized with a thick K-wire. Okay, that's the treatment of choice. Coming to complications of Galeacy fracture, it's a highly controversial area. Aptly says the most common nerve that is involved is ulnar. Watson-Jones says the most common nerve is anterior interosseous. So, it's a highly controversial area. We should pray to God that this question should not appear in our NEET exam. Okay. And without controversy, the most common tendon that gets entrapped or tendon that gets damaged in Galeacy fracture is extensor carpi ulnaris tendon. Extensor carpi ulnaris tendon. Okay. So far, what we had seen is called Galeacy fracture. Dear friends, please remember Galeacy sign is entirely different. Already in the main class, already I taught you where Galeacy sign comes. Just recollect. I will count 3, 3, 2, 1. Galeacy sign seen in case of congenital dislocation hip. CDH. This is otherwise called developmental dysplasia hip. DDH. CDH or DDH. What is Galeacy sign in DDH or CDH? Very simple. Make the baby lie down in an examination couch in supine position. Flex both the hip joint to 90 degree. Flex both the knee joint to 90 degree. Normally speaking, both the knee joint should be at the same level. If it's a case of developmental dysplasia hip on the affected side, the knee joint will be at lower level. That is called Galeacy sign. This is otherwise called Alice test. So Galeacy sign or Alice test is positive in DDH. Galeacy fracture is totally different. Okay. Now coming to the next fracture, radial styloid fracture. Radial styloid fracture is otherwise called Schaffer's fracture. Okay. Why it's called Schaffer fracture? First of all, we should know who is a Schaffer, and most of you may be knowing who is a Schaffer. Schaffer is nobody, nothing but a driver. Drives a car, chauffeur. Okay, English, no, the name varies from place to place. A simple somebody is driving a simple Maruti car, he is called a driver. The same guy who is driving a Mercedes Benz or BMW is called a chauffeur. Okay, a guy who is just doing cooking in a simple hotel, he is called a cook. In a 5-star hotel, he is called a chef. Okay, the purpose is the same, but the name varies. Like that, chauffeur is nothing but a high-class driver. That's all. Why it's called Schaffer's fracture? You should know this. Very simple. Why this radial styloid? You all know radial styloid. You know this is the styloid process. This is the distalmost portion of radius. Distalmost portion of the radius. This part is called radial styloid. This part is called radial styloid. And you're able to see a fracture here. Able to see a fracture here. This is a classical radial styloid fracture. Why this is called Schaffer fracture? See, before self-starter was invented, self-starter everyone knows, no, car. Just you're starting a car with a key, chuck, it will start. Nowadays everything push button. Okay, self-starter. Self-starter was invented by the great Henry Ford, founder of Ford Car Company. Before Henry Ford, there was no self-starter. So how to start a car? Probably you have seen in vintage old English pictures, Titanic, you go and see that. So in old pictures, okay, vintage historical movies. So how to start a car? They used to come in front of the car. There will be a hole which is connected to the engine. They will connect a rod that's called handle. Driver has to do like this. Olden days, Lord, they won't drive the car. They will be having a permanent driver. So once the engine gets started, it will give a backfire. The rod will come and hit the radial styloid. Very frequently, drivers were developing the radial styloid fracture. So that was called Schaffer's fracture. Nowadays, it won't happen because everybody's push button. Okay. So it is called, for historical importance, even somebody has named fracture, Schaffer's fracture, should know it is nothing but the radial styloid fracture. Okay, so Schaffer's fracture is otherwise called backfire fracture because the rod is giving back. This was first demonstrated by the great physician Hutchinson. So this is called Hutchinson's fracture. So what are the synonyms? Radial styloid fracture, backfire fracture, Schaffer's fracture, Hutchinson's fracture. All the four are one and the same. Okay, coming to treatment of radial styloid fracture, the best management of the fracture is best treated by closed reduction and below elbow POP cast. This is the standard treatment of choice. You can forget about this line. The treatment of choice is below elbow POP cast. Below elbow POP cast. That's the treatment of choice. Coming to the next fracture, Barton's fracture. Barton's fracture is a vertical, marginal, intra-articular fracture of the lower end of radius. Dear friends, distal radial fractures are divided into 4 main types. Distalmost portion of radius, 4 fractures are possible. Number 1, radial styloid is possible. Number 2, Barton is possible. Number 3, Colles is possible. Number 4, Smith is possible. We are seeing the second fracture. What are the 4 fractures that can happen in distal radius? Radial styloid, Barton, Colles, Smith. Okay, so radial styloid we had seen. What is Barton? When there is a distal radial fracture and that is intra-articular, that is extending inside the joint, that is called Barton. So that's the definition. It's a vertical, marginal, intra-articular. This is the most important point. Intra-articular fracture of the lower end of radius. If the fracture is extra-articular outside the joint, that's called Colles. That's called Colles. When it's inside the joint, that's called Barton. Barton's fracture is of 2 types. Olar Barton, dorsal Barton. Most common type is Olar Barton. This is called true Barton, other is called classical Barton. This is called classical Barton. When in a question paper, they are asking a question, Barton's fracture, they are meaning only Olar Barton. Dorsal Barton is very rare. Okay. So Barton means it is classical. It is called Olar Barton. So the distal fragment is displaced Olar aspect, the flexor aspect. That is called Olar Barton. Treatment of choice for Olar Barton fracture is anterior buttress plating. Treatment of choice for dorsal Barton is closed reduction and above elbow POP slab. So you see the difference. If it is Olar Barton, treatment of choice is plating, open surgery. It is dorsal Barton, you can manage conservatively. Okay, that completes Barton's fracture.